And good evening. So excited to have you at a special night session. Dr. Berkowitz, who normally does neuro VMR, is on service right now, so we didn't have our normal neuro VMR, but I thought that it would be a lot of fun to do a little bit of a different format. And so how the format is going to work is basically I have a case. It was supposed to be 100% prepared, but it is not. So it's, I'll be doing it in process. But basically, I am going to ask Maria and Thiago their thought process in kind of going through this case and how they would approach it. And then they're going to have to ask me kind of for what labs and further evaluation they want. And I will try my best to provide that information if it is available. So both Maria and Thiago know that it is a case about hypoglycemia, but that is all that they know. And so then we're going to just go from there. And so I thought that since it's a night session and everything, that we could just go ahead and get the show on the road immediately. So if whoever is doing teaching points wants to share their board, and then I am just going to open it up. Thank you so much, Shakriti. I'm going to open it up and first ask Maria about kind of if she hears that someone's presenting with hypoglycemia, what's her approach? Then Thiago is going to weigh in, and then I'll give HPI and they can ask me for what else they want.
Yeah, that sounds good. So hypoglycemia, for me, it definitely comes it's like Aaron says, like thinking fast and thinking slow. So definitely thinking fast treatment. We definitely don't want like the causes of hypoglycemia, and that's really it's gonna depend, like if you're seeing this patient in the emergency and he's seizing and then they get like a stick glucose. So definitely treatment first and seeing like, how emergent is it? So that's like definitely my thinking fast approach, not really concerning what's causing the hypoglycemia, just hypoglycemia, we have to treat it. And then, depending on like the risk factors for the patient, I was just reading about it a couple days ago that, you have to administer thiamine first before hypoglycemia in people who have like malnutrition or alcohol abuse. But then they saw that people were just like taking so long to get the thiamine and not passing the glucose. So definitely pass the glucose even if you don't have the thiamine like at hand, and then administer the thiamine, just because severe hypoglycemia, can be deadly. So that's my thinking fast. And then my thinking slow in terms of what's causing the hypoglycemia. Definitely you want to go back and see who is this patient and, the risk factors and the past medical history. So, for example, if it's like a newly diagnosed diabetic patient who just started using insulin, that's going to be like my first thought, of course. So definitely checking for meds, and then checking for like nutritional status, is the patient adequately eating, or, the patient just came back from like hiking and getting lost in the forest for 5 days and not eating anything. So both of those things, like past medical history and then the meds they're taking, I think would be my first step into really getting to understand what's causing the hypoglycemia.
I loved it, Maria, and I cannot agree more with you. It depends on the setting that you are. If you are in the emergency room, then you just treat it. You don't know what's going on, but you need to fix it. It can cause seizure, it can cause loss of consciousness, and you don't want problems. After that, thinking about diagnosis, my first point is, does this person have diabetes? Because we know that the most common cause of hypoglycemia is using a drug that causes hypoglycemia, like insulin or sulfonylurea. Then diabetes. and no diabetes. So that would be my first, thinking about diagnosis, that's my first point. So if the person does not have diabetes, then I think, is it true? Because many patients say they have hypoglycemia and they don't have at all. So most patients that come to attention, I'm talking about outpatient clinic, not in the hospital, but in the outpatient clinic, most patients that come to attention, they don't have hypoglycemia. So how can we define hypoglycemia? That's very important, because many physicians, many medical students, they think that if you have a blood sugar less than 70, it is hypoglycemia. And that's not true. So we define hypoglycemia as 70 for those people who have diabetes and use drugs, increasing the risk for hypoglycemia. But if you don't have hypoglycemia, you can have blood glucose levels like 60, and that's no problem at all. So why this definition of 70? It's because that's the threshold in which most people will activate neuroendocrine response, meaning other hormones are going to increase: glucagon, GH, cortisol, epinephrine. So if the person does not have diabetes, then we have to think about the Whipple's triad, having symptoms and signs of hypoglycemia. You can then divide into symptoms and signs: neurogenic, autonomic, the same, or neuroglycopenic. And so the symptoms can be from sweating, tremors, the neurogenic more common symptoms and signs are those, anxiety, and the neuroglycopenic, meaning that are low sugar in your brain. Then you can have confusion, fatigue, loss of consciousness, and seizure. You know, if you have hypoglycemia, your heart will not suffer, because heart uses the fat in the surroundings, but the brain cannot use it. The brain just uses glucose. They cannot use fat. They do not perform beta oxidation. So neuroglycopenic symptoms and autonomic symptoms, then a low blood glucose, and then a recovery after receiving glucose. So this is Whipple's triad. So diabetes, no diabetes, Whipple's triad, positive or negative. And then if it's positive, then you should investigate. And then I think, is it insulin dependent or not insulin dependent? So that's the way I approach hypoglycemia. And so the first thing I want to know is diabetes, no diabetes, then Whipple's triad, yes or no? And, you know, for you to consider there is a hypoglycemia in those people without diabetes, the blood glucose should be below 55. You know, finger C glucose, they are not so, we trust them, but they make mistakes. So in the definition, it's venous blood glucose less than 55, but just be aware that 60 is nothing, but 60 may be something if the person has symptoms, because finger stick can be wrong and the venous sample could be 50 with a finger stick of 60. And so that's my initial thoughts. I'll pass it on to you, Anne.
I love it. Can I just say something really quick?
Of course, Maria, go for it.
Yeah, I totally forgot, you know, like the Whipple's triad is something that, you know, as a student, it just sounds really silly because it's like a triad for hypoglycemia. And it's just like, you know, who came up with it? Because it's just like symptoms of hypoglycemia, like getting like the test that tells you that you have hypoglycemia, and then, you know, recovering from hypoglycemia with sugar. But it definitely helps you. You know, when that's negative, then you really have to think about the mimickers. And, you know, one of the most important ones is like that Tiago was saying, like the abnormal stick glucose. So like if you have like a vasoconstriction and then you're not getting an adequate blood supply, and then you keep doing like stick glucose, you're always going to come back negative, even if you're passing dextrose. So it was a good reminder, because I always like thought it was just such a silly triad, but it's so important that, you know, it really helps you not go down a path that is wrong. So when you're thinking hypoglycemia and it just doesn't correct, it's definitely not that. So I really like that reminder of the triad. Thiago, thank you.
Great discussion so far. It's so great to hear both of y'all discuss hypoglycemia. So a little bit more history. It is a 78-year-old female presenting with worsening hypoglycemia. 2 weeks ago, she had a hip arthroplasty, which was reported as an uncomplicated procedure. And since that time, she's had worsening hypoglycemia. She was brought in by her family from her SNF. She did have frequent episodes of hypoglycemia prior to this and had been following with an endocrinologist in the community for a year. Had received several CTs of the abdomen and pelvis that did not show any abnormalities, and then had received past labs that showed a random glucose of 93, a random insulin of 122, an IGF 1 level of 50, and then a renin level of 2.5 and an aldosterone level of 7.2. She did not have any history of diabetes. She was started on glucose tablets, and then octreotide was trialed, but she did not tolerate it well due to GI side effects, and that was stopped. She's also had a negative sulfonylurea screen in the past. She had been, doing okay with frequent meals, but then since the procedure 2 weeks ago, she has basically been having to take glucose pills every 1 to 2 hours and has had frequent blood glucoses documented at about 35. She will frequently get diaphoretic and altered with these episodes of low blood glucose, and so her daughters were so concerned that they brought her in. The surgeon had looked at her surgical site and a few days prior and did not have concerns for infection at that time. She's not had any fevers or chills. She has had about 25 pounds of weight gain in the past year, and then about 10 pounds of weight gain in the past 2 weeks. Past medical history includes a history of hypertension. And then medications include, let me pull them up really quickly. Oh, and then she also had a history of peripheral arterial disease. And then the medications include Plavix, hydrochlorothiazide, lisinopril, potassium tablets, and as needed glucagon and glucose tablets. And then no significant family history. She does not use tobacco products, alcohol products, and no illegal drug use or anything like that. Up to date on health-related behaviors and no relevant allergies. So Maria, what are your thoughts after this?
This is really complicated, but I definitely, there's some things that stuck out to me. I'm not really sure how to interpret the labs because I'm not quite familiar with like the normal levels and everything, but like 2 things point out to me. First, when you're evaluating glucose disorders, always you have to take into consideration like when is it happening, like the trigger, and you can divide that between like a simple schema is depending on how prolonged they can tolerate like a fast. So for example, in people who can tolerate fast, like they're starting to develop hypoglycemia after hours or even days. You can think about like gluconeogenesis disorders, which is like what really lets you keep having glucose after it's run out. But in this case, the patient cannot tolerate even like small amounts of fast. So that points out to me that she has a disorder, for example, like maybe hyperinsulinemia, or she's not storing glucose, because definitely like she's eating and she's not being able to like she's not being able to like have stable levels of glucose even after a couple of hours. So my first thought was hyperinsulinemia. And then the other thing that really stuck out to me was that this worsened after a surgery. So things that could get worse after surgery, make me think of definitely adrenal insufficiency. And for that, I think we would have to get like, well, I don't know, did she have like something that suggested that before? But I don't really know, like if she tolerated the surgery adequately and then developed it 2 weeks later. I don't know. I think adrenal insufficiency would present like much sooner after the surgery. I don't know if that makes sense. Like I would expect that during the surgery she would get decompensated and not like 2 weeks later. But then like all other things like malnutrition that can get worse after like a stressful event. And then another thing that stuck out to me was her age, because every time where I see older patients getting hypoglycemia, I worry about like a fictitious disorder. And then you usually think about like fictitious disorder by proxy with kids, but then grown adults are really vulnerable to it as well. So always it's good to like investigate if this episodes of hypoglycemia are happening with like a certain relative, or if somebody in the family has problems with like diabetes. Even if she doesn't, maybe there's like pills around or like insulin around that she may be vulnerable to getting. And yeah, those are my initial thoughts. I think it's really complicated, but I'd be interested in like getting more facts about like, is her insulin level high? So for example, things that would pull me away from that are like ketone body. So like no ketones, because you can't get ketones if you have insulin, and then like C-peptide as well, to consider hyperinsulinemia first. And yeah, those are my thoughts.
Wow, great case. So, Anne-Marie, I'm not worried about her EGF. There is IGF-related cause for hypoglycemia, so mesenchymal tumors producing IGF, leading to hypoglycemia, but it's IGF-2, and we are used to measure IGF-1. So when I see IGF, it looks like it's IGF-1. I don't know if it's IGF-2. And IGF-1 reference range changes based on sex and age. I don't know if it's normal, but I have the impression IGF-1 of 50 for this age and sex is normal. But even if it's not normal, I'm not thinking about, there is nothing specific to think about. So regarding her renin and aldosterone, it looks like normal. It depends on the setting again, but she has hypertension. She's taking medications for hypertension. I don't know how her blood pressure is right now, but it decreases the likelihood of it being primary adrenal insufficiency. It can be secondary, but primary is very unlikely. The fact that he is gaining weight is another point against adrenal insufficiency, because virtually all patients with adrenal insufficiency, they are losing weight instead of gaining weight. So she is taking a lot of medications like octreotide. We use octreotide to treat hypoglycemia when the cause is nesidoblastosis. So that's the only setting in which we use it, or an insulinoma that has been resected and it came back. So I don't know what was investigated with her physician. But I think that the main point here is what does this insulin of 100 and something tells us? Nothing. Why? Because we need to measure it during the hypoglycemia. So if there is hypoglycemia, I mean, if the Whipple's triad has been documented, then what do I think? If it's not diabetes and Whipple's triad is documented, so the first thing, is it a clear cause? Is the cause evident? And when is the cause evident? When the person takes insulin or sulfonylurea or alcohol. So that does not look the case. And she can use insulin, as you said, Maria, because she cannot disclose it to you, but she can be using insulin from others. Is there hepatic failure? Because you can expect hypoglycemia if you have hepatic failure because your gluconeogenesis is compromised. Is there renal failure? Because if you have it, then you do not have sufficient alanine, and then you can have hypoglycemia, so the cause is evident. Is there a high suspicion for AI, adrenal insufficiency? I think that at this point, there is no high suspicion for adrenal insufficiency, but if I see a hyponatremia and a hypoglycemia, then I think about adrenal insufficiency, because most patients with adrenal insufficiency, they have hyponatremia. But as I said, it's unlikely because she's gaining weight, she has hypertension, so it's unlikely. So at this point, I see if it's hypoglycemia again, because the glucose was normal 93, then we need more data because it's not evident the cause. So she does not have hypoglycemia at this point, so we want to see a hypoglycemia. And we can recreate the setting in which she has hypoglycemia. In the past, hypoglycemia was divided in post-meal or fasting. We don't use this distinction anymore because, insulinoma is much more common to present with fasting hypoglycemia, but you can have an insulinoma with a post-meal hypoglycemia. So it's a data to have, but not something that will point you out to a specific diagnosis. So what I would like to see, I would like to see her hypoglycemia, and then during the episode of hypoglycemia, measure insulin, C-peptide, proinsulin, sulfonylureas during the episode of hypoglycemia, because sulfonylureas were normal, but she was not having hypoglycemia. Beta hydroxybutyrate. So we want to have all of it during an episode in which glucose is below 55. So that's what we want. And then we can define if it's insulin dependent or not insulin dependent. And as I said, we can recreate the setting. So there is the fasting test in which the person staying fast for up to 72 hours. And we stay there just measuring glucose every 6 hours. Once it's below 60 every hour or 2 hours until we have the episode, and then we can measure everything. Or if it's post-meal, then we can recreate her meal. It's her meal. And then we can do the same, just measure it until we find the episode of hypoglycemia, because we need it. As the cause is not evident, we need the hypoglycemia, and then we need many parameters to decide if it's insulinoma, if it's NIPS, and if it's exogenous insulin, if it's not related to insulin, if it's IGF-2, if it's antibody-related hypoglycemia. So there are many hypotheses. All of those are rare, but we need lab data. And the imaging, it does not help, because every time in endocrinology, the diagnosis is biochemical. Once you have the diagnosis, then you proceed to the imaging, because it can be an insulinoma for sure. Most insulinomas, you see it in the CT, but there are some insulinomas you don't see it in the CT. And even if you find an image there in pancreas, how can you say it's an insulinoma? You cannot. It can be nothing. It can be just a small nodule inside the pancreas, which is not producing insulin. So the diagnosis is biochemical. So that's what I think when I see this case.
Okay, awesome discussion. So the temperature afebrile, heart rate between 80 and 100, oxygen saturation 89% on room air, which improved to 98% when 1 liter of oxygen was placed. Respiratory rate 18, and blood pressure 114 over 66. The exam, when originally examined, was alert and able to answer questions, although had an episode witnessed in the emergency room where became less responsive and did not answer questions until given glucose. Then otherwise, the most notable findings were there was mild erythema over the surgical site, but no purulent drainage. And then there was about 3+ edema in the lower extremities bilaterally. The lungs were clear to auscultation and the JVP was not elevated. There was no other rashes or skin changes. As far as the labs, the sodium level was 127. The potassium was 4.3. The creatinine was 0.56. The glucose was 72. The albumin was 3. And then the rest of the hepatic function panel was within the normal range. And then the CBC showed a normal WBC and a normal differential, a hemoglobin of 9, and platelets of 286. Okay. While in the emergency room, she was originally started on a D10 drip due to some very mild hypoglycemia, but that was stopped and the patient was observed, and 2 hours later became altered and the glucose was checked and was 35 at that time. So I know Thiago has mentioned some of the labs that are wanted, but I just wanted to see kind of what labs or evaluation you wanted this time.
Yeah, I think this is so interesting because there's definitely things I wasn't expecting to see in like a normal case of hypoglycemia. So first, vitals, like the oxygen saturation is way lower and than I would expect, and there's nothing really that I can think of like metabolic wise that might explain that. So I'm definitely thinking of like checking her lungs and see what's that about. And then there's some things that can be related to hypoglycemia, for example, sepsis, but she's been having this hypoglycemia for a long while. So even like if it's pneumonia or the surgical site is infected, that would not be explaining the hypoglycemia she's been having for the past year. Maybe she has some sort of malignancy in the lungs. That's like the Warburg effect that can be causing hypoglycemia, but she doesn't have any signs of like chronic constitutional signs like weight loss, fatigue, to make me think of that as well. So I'd really the other thing is that like she has edema, so it can be like a fluid overload that's causing it. So that's with like the vitals, and then there's nothing really that points us to anything else in the physical exam. I know that, for example, there's some really cool clues to hypercortisolemia, and then, for example, like the I forgot how to say that. the red things on their abdomen and like the cushingoid face. That to like point out to hypercortisolemia, but I'm not seeing it here right now in the physical exam at least. Then with the labs, the other thing that's really interesting is the hyponatremia. Definitely thinking of something more in terms of maybe, oh my God, I'm forgetting all of the words. Wait, Tiago just said it. Hyponatremia, hypoglycemia makes me think about hypocortisolemia in terms of like adrenal insufficiency. That's the word I was looking for. But then I would also expect the potassium level to be different than this. So I'm not really sure what to think about like the hyponatremia and the hypoglycemia on its own, but definitely all of this points us out, moves us away from the most common causes. So it's definitely not like a factitious disorder involving insulin and or sulfonylureas, because that would not explain like the oxygen level or the hyponatremia. It's definitely pulling me away from like insulinomas, because that would also not explain that. So I'm thinking I would probably like to get more hormonal levels, especially cortisol in AM, and then get the curves, the insulin and glucose curves that Tiago was asking for at the beginning.
Amazing, Maria. Do you wanna go ahead, Anne-Marie?
Okay, so I believe that you ask for an insulin level, and this would be while the blood glucose was 35, the insulin level was 31 with a reference range between 2 and 37. And then what other labs would you like?
Cortisol.
So a cortisol was obtained at the time. It was an afternoon cortisol, and it was 8.5.
And then I don't know if you have like other things that was taken out during the hypoglycemia event, like maybe C-peptide and like ketones.
Okay, so C-peptide was 12.8 during the hypoglycemic episode, which is high. And then beta hydroxybutyrate level was 0.03. Tiago, any other labs that you'd like?
So we like a lot of labs. Whatever you have, it's good. But you know, proinsulin is not needed in this case because we know insulin is high. But there are some insulinomas in which proinsulin is high and insulin is normal. So when if you follow the protocol that was established at Mayo Clinic, it's used worldwide. So I'm from Brazil, and we use this protocol here. And this protocol, you would have insulin, proinsulin, C-peptide, beta hydroxybutyrate, which you already said, C-peptide, sulfonylureas during the episode, and antibodies, insulin and insulin receptor, so both antibodies.
And insulin antibodies were negative. And then I do have a proinsulin level, which was 410.
Okay, so just a remark here. So as I said, it is not adrenal. It doesn't look like adrenal insufficiency, and now I'm sure it's not adrenal insufficiency. But as I said, some commentaries here in the chat. Hyponatremia is very common in patients with adrenal insufficiency. Over 90% of the patients, regardless of it being primary or secondary, it's more common than primary. But the reason the most important reason for you to have hyponatremia in adrenal insufficiency is because low cortisol, you have high AGH. So that's the reason. And hyperkalemia, it's not common in adrenal insufficiency. So secondary adrenal insufficiency, you will not have hyperkalemia because aldosterone is normal. And even in primary adrenal insufficiency, about 30% of the patients have hyperkalemia, meaning that most patients with primary adrenal insufficiency, they have a normal potassium. So a peril for primary adrenal insufficiency. Over 95% of the patients have hyperpigmentation and hyponatremia, but don't worry about potassium. Okay, so if it's high, good for you to think about, but if it's not high, no problem. But we know from the last exams that it is insulin-dependent hyperglycemia. So that's not adrenal insufficiency, because adrenal insufficiency is not related to insulin. That's not the reason you have hypoglycemia. So that's not the case here. But if you have hypoglycemia that is not related to insulin, what's it? 4 causes: drugs, critical illnesses, hormone deficiency, adrenal insufficiency, or non-islet cell tumor, which is IGF-2 related tumors. But those causes are excluded here. That's not it.
Yeah.
So
Thiago, can I ask you a question? Because obviously these labs take a long time to come back, and in real life, don't have the labs, take several days. So would you do an ACTH stimulation test while you were waiting for these labs to come back?
That's a great question. Based on the history, I wouldn't. There is a hyponatremia. As Maria said, she had a surgery and now she's coming back. Is it hypoglycemia? It looks like she has hypoglycemia for a long time. So it looks like something acute is happening. I agree with her. I don't know if it's a pneumonia, if it's a venous thrombosis. So why does she have hyponatremia? I don't know. Probably it's related to an acute situation, but it's very unlikely to be adrenal insufficiency. Why? Because she's gaining weight again, and her pressure is normal, and she's taking antihypertensive medications. So even with primary adrenal insufficiency, you have a level of hypotension, not as severe as in primary adrenal insufficiency. So I don't see a problem. I have to think more about it because, as you said, when you have a case, you stay there for maybe 30 minutes, 1 hour thinking about it, and then without the labs. So maybe you can use 50 milligrams hydrocortisone just because I'm in doubt. It's no problem at all. I don't know if I would use it based on gaining weight, normal pressure, blood pressure, and a long-standing hypoglycemia with gaining weight. It suggests insulin because insulin is anabolic, right? So if you have high insulin, you gain weight. And as I said, virtually all patients with adrenal insufficiency, they are losing weight. So another good thing about adrenal insufficiency, because many people, they are afraid they have adrenal insufficiency because they type it on the internet and it says adrenal fatigue, and this it does not exist, but people are afraid they have adrenal insufficiency. But virtually all patients with adrenal insufficiency, they are losing weight. So if she has a long-standing hypoglycemia and she's gaining weight, I'm not sure, Anne, but I wouldn't, but I'm not sure. Maybe this, after seeing this sodium, I would be like, oh, just give it, and then we see in the future. But it's unlikely, but I'm not sure. I'm not sure, but I don't think so.
We did, just because we did an ACTH stimulation test. It's a pretty easy test to do. And the cortisol did rise to 27. And really the only reason why we did it is the cortisol was low while the glucose was low. And so we're like, maybe it's an inappropriate response. But it appropriately rose to 27.
It's very well described that, in patients, so we use that. Can I talk about adrenal insufficiency diagnosis? Okay, so adrenal insufficiency diagnosis. If you have a cortisol, a basal cortisol in the morning, less than 3, it's very likely to be adrenal insufficiency. If it's less than 5, it's likely to be adrenal insufficiency. If it's over 14, it's very unlikely to be adrenal insufficiency. It's over 18, it's not adrenal insufficiency. But most patients, they have this 8, 10. If we do it in ourselves, it probably will be 8, 10. But then it depends on the time of the day. I'm talking about in the morning. But then when you want to confirm adrenal insufficiency, because the cortisol is age 10, you have two tests: cortisone ACTH synthetic test, which you did, and it's the best test. And the other test is insulin tolerance test, ITT. You put the glucose below 35, and then you expect the cortisol to go high. Okay, that's to diagnose adrenal insufficiency. But for a person who has an insulinoma, for example, that's not the response. Because when you have low glucose, as Anne-Marie said, you expect high cortisol, higher than 18. But that's true if you don't have hypoglycemia. So I don't have hypoglycemia. If you give me insulin and then put my glucose below 35, my cortisol will be very high, higher than 18. But you see this woman, she had not a high cortisol, even with a low glucose. But it happens when you have hypoglycemia. So ITT, meaning having hypoglycemia, is not a good test for adrenal insufficiency if you have a disease that causes hypoglycemia. That's what I'm talking about, because you can use it as a test, but if you have hypoglycemia, forget it. It's very well described. Don't use it. And as I said, I can say that it's not, the hypoglycemia is not related to adrenal insufficiency because the insulin is high. But as Anne-Marie said, there is a time, there is a lag. So during a time you are like, oh, the cortisol is not so high, there is hyponatremia, there is hypoglycemia. So what's going on? And that's real life, right, Anne?
Yeah, definitely. So, in real life, we didn't have all these labs back. The patient is admitted, started on really high rates of D10, getting very volume overloaded because of the rates of D10 that we're having to give. And in a tough situation, trying to balance the sodium, the glucose and everything, because the glucose is still falling to like the 30s and 40s, even like on D10 and everything. So at this point, what would be kind of, while you're, pretend we don't have these labs back and while we're waiting, what would you be doing in the meantime? And any other like labs or evaluation that you want?
Wow, this is really hard because, hyponatremia and then hypoglycemia, and it looks like you're not being able to control hypoglycemia because, for example, like in insulinomas, even the patients learn how to control their hypoglycemia by like diminishing their fasting time, and then they just start consuming more food, and the patients get overweight, but they don't usually experience very severe hypoglycemias because they resolve it through food. And it looks like you're having a really hard time even controlling her hypoglycemia. So that's making me worried because we know now that we have insulin provoking this hypoglycemia, and I'm assuming like she's not in any contact with like exogenous insulin or just insulin because she has a positive C-peptide. So that can't be it. And then, I'm not really sure what to do with like this worsening hypoglycemia requiring constant glucose administration, because what I've seen with insulin dependent hypoglycemia is that they usually get like a time where they are able to just eat or have like some glucose in them, and then that's being controlled. So I'm worrying about, like insulinomas and like nesidioblastosis, which is like maybe that's one of the reasons why her imaging came back negative. And yeah, I agree with Thiago, like biochemistry wise, it's usually what determines like the endocrine and pathologies, but also like in gastrointestinal pathologies, there's so many imaging that can be done, like the CT scan is good for some stuff, but then like a pancreas, for example, it's really hard to get a sense of true tumors in the pancreas. So maybe even considering doing like a endoscopic ultrasound, looking for like a mass secreting insulin. But then, as Tiago said, like, how could we be sure that that is a mass that's secreting insulin? It comes back to like venous sampling. But I don't know if that's consistent with like the case that we're having. I'm worrying about like maybe like a Hickam dictum, and maybe she has like some basic pathology that's causing her hypoglycemia for like the past year, and then now she's septic, not really, because she doesn't have like fever or white blood cell count or anything that's like increasing her glucose demand. Or I don't know, it seems like acute on chronic, and I'm not sure like what's the chronic or what's the acute. So really difficult.
So I just want to make it clear how I think about this diagnosis. So first, is it hypoglycemia? Yes, it is. 35. So I said that you should have symptoms. Whipple's triad. But people who have frequent hypoglycemias, they change the set point. So if you see a glycemia that's below 45, believe it's hypoglycemia regardless of symptoms. So she has hypoglycemia. And now we know it's insulin dependent. Why? Because during an episode of hypoglycemia, her insulin is over 3. So once it's over 3, it's insulin dependent. And but you know, this insulin can be because of sulfonylureas, and we know that's not the case. Why? Because sulfonylureas were negative. We know that it's endogenous. How we know it's endogenous? Because C-peptide is high. So we can narrow down our differential diagnosis a lot. We know it's not IGF-2 dependent as well, because insulin is low when it's IGF-2 dependent. We know the antibodies are negative. So there are just few diagnoses here: insulinoma or nesidoblastosis, which is non-insulinoma pancreatogenous hypoglycemia syndrome, NIPS. So just these two possibilities. So from the diagnosis standpoint, the next step is imaging. She has a normal CT, you can have an MRI or an endoscopic ultrasound. But while you wait for these exams, hypoglycemia is happening, as Emery said. So you have to try to avoid it. How can you avoid it? Many times per day, and using medications to suppress insulin, because we know it's endogenous insulin. And how can we suppress it? Diazoxide, I don't know if my pronunciation is correct, please correct me, diazoxide and octreotide mainly. So because it suppresses insulin production regardless of the reason it's being produced. So we can use it while we wait for the next steps. And I'll pass it on to you, Anne.
Okay. So she was started on diazoxide, which I also do not know if my pronunciation is correct, which basically helps decrease insulin production, as well as verapamil, which maybe Thiago can explain, due to like a calcium dependent mechanism, is also supposed to decrease insulin production. And the amount of fluids that were required did decrease, was also receiving IV Lasix for the edema. I got a repeat CT scan that was a pancreas protocol that did not show any abnormalities in the pancreas, and then got an endoscopic ultrasound to look for possible endocrine tumor that was suboptimal, but also did not show any abnormalities. So what would be your next steps, Thiago, kind of after this?
Okay, so yeah, it's very interesting because calcium stimulates, when you have a disease that produces insulin, you give calcium, insulin gets higher. So if you inhibit calcium, then it's going to be lower. But just when you have nesidoblastosis or insulinoma, not for normal pancreas, normal beta cells, normal islets. So if you use a calcium channel blocker and the person is healthy, not going to happen. But if the person has nesidoblastosis or insulinoma, then you will decrease insulin secretion. So we have two options here. with these exams normal, because we know it's endogenous insulin, we know it's nesidioblastosis or insulinoma. So there are two options, depending on the service that you are in. You can go to surgery and then explore in the surgery, because most insulinomas, they are inside the pancreas, and you can use ultrasound inside the surgery. So you open it, then you use an ultrasound, and then you find it. And if you don't find it, probably it's nesidioblastosis. And you have the best approach, which is let's use our gold standard exam for localization, which is a calcium, selective arterial calcium stimulation. Because as I said, calcium will stimulate cells that have disease to produce insulin. And then you measure it in the hepatic event. So you use different arteries. Which arteries? I'm not sure, but I think it's splenic, gastroduodenal, and the superior mesenteric. So, and then you just infuse calcium gluconate. And then you measure at this different, you wait for sure, not three at the same time. Splenic, then you wait, superior mesenteric, then you wait, and then the gastroduodenal. And then you measure what's going on with the insulin in the hepatic events. And then you can localize. And if you localize it, probably it is insulinoma, because nesidioblastosis is more diffuse. And then it changes the way you will do the surgery, but probably she will have a surgery. So what did you do, Anne-Marie?
Ultimately, there was a lot of discussion, and then the patient ended up actually getting a scan that did show uptake in the pancreatic head, and then an MRI that showed a 5-centimeter enhancing mass at the anterior pancreatic head that could represent an insulinoma or endocrine tumor. Ultimately, it was decided that the patient's goal was to go home and not be in hospital, and so further evaluation was not obtained at that time. So that is the case conclusion. Does anyone have any final thoughts, comments, anything like that?
Sorry, I missed it that there was no MRI, because MRI is easier than a calcium measure. So yeah, and MRI is better than CT, but worse than endoscopic ultrasound. So yeah, and I don't know, I'm just wondering, why didn't they find the image on the CT? Because it's big. It's 5 centimeters, and most insulinomas, they are small. They have less than 2 centimeters. Most insulinomas, but you can have different size. So I'm glad that's insulinoma, because it has a very good prognosis. People with insulinoma, actually, they have the same prognosis as people who do not have insulinoma. Once you resect it, it's okay. 10% are malignant, but most malignant insulinomas, you don't have hypoglycemia. When the cell is specialized and it causes hypoglycemia, the likelihood of being malignant is very low. So probably she is cured after the surgery.
Yeah. Thiago, in response to your point, kind of a further read after the MRI said, in retrospect, looking back at the CT, there probably was an area of hyperenhancement. It was just very subtle. And then kind of some of the volume overload, I think, was just driven by frequently eating and everything. And then there's probably some heart failure with preserved ejection fraction. The TTE showed a normal EF at that point. I know dioxide can sometimes cause edema related to that, but that was kind of my thoughts on some of that. So any final reflections before teaching points?
Wow, Anne-Marie, I love this case. Before I wanted to be a neurologist, I wanted to be a hepatopancreatic biliary surgeon because pancreatic surgery, I really, really like those surgeries, and I always considered it. And yeah, I think this was a really interesting case. And as Thiago said, insulinomas are, you don't if like you get a choice, you definitely don't want a pancreatic malignancy, but if you do, you definitely want it to be an insulinoma. And then, yeah, of course, a little bit of Hickham's dictum to like complicate the case, because like insulinoma wouldn't explain like the oxygen need and like the hyponatremia, but that's what like elderly patients have. Like they have a lot of diseases that we need to take care of, and it's definitely, you know, a team effort to get that covered. So I really like that case.
So just can you ask here if insulinoma is a PNET? PNET stands for primitive neuroectodermal tumor, and yes, it is. And Vivek said about hyponatremia. I don't know how to explain hyponatremia. I think it's not related to insulinoma, but please let us know, Anne-Marie. And thank you very much for presenting this case. It was very good. Thank you.
Okay. Yeah, I think it was just volume overload. I know that again, the treatment, the dioxide, can sometimes cause it, but I think that in this case, it was just frequently like having to take in glucose and like fluids for that in the setting of probably heart failure. It's kind of how I put it together. TSH was normal and everything. So I am so excited for teaching points to recap all the awesome learning. Amazing job, Maria and Thiago.
Yeah, thank you, Anne-Marie, for the case. And I learned so much from Thiago and Maria's discussion today. So just going back to the initial presenting, so we were looking at a case of hypoglycemia. So when we're thinking about hypoglycemia, there's things to think fast about. Those are the initial approach in terms of treatment, as well as thinking if the patient is malnutritioned, we also need to supplement thiamine before we give the glucose to avoid Wernicke's encephalopathy and other issues that might be caused by that. And then when we're thinking more slowly and thinking about the diagnostic process and the diagnostic approach to hypoglycemia, things to consider would be nutrition status, medications, as well as does the patient have diabetes? That should be the first question to ask. And when we're thinking about the base rate of disease, the most common cause of hypoglycemia is usually in patients with diabetes who might have taken extra insulin or somehow have extra sulfonylurea use, which could lead to hypoglycemia. So the first thing is to ask if the patient has diabetes. The second thing to consider is this true hypoglycemia? Sometimes finger sticks might not be an accurate representation of the glucose. So using the venous blood glucose is what's used in the definition of hypoglycemia. And the definition might be different based on if the patient has diabetes or doesn't. So blood glucose less than 70 if they have diabetes, or less than 55 if they do not. And then if they don't have diabetes, then we want to see if they have symptoms that are related to Whipple's triad. So Whipple's triad includes hypoglycemia measured less than 50 to 55, and then symptoms of both either adrenergic or neuroglycopenic symptoms, as well as relief of those symptoms when the hypoglycemia is treated with glucose. And then the next branch point when we're thinking about hypoglycemia is whether it's insulin dependent or if it's insulin independent. So the labs that should be drawn to determine this for the insulin level should always be done during the hypoglycemic episode to have a more accurate representation of the insulin levels. And things and clues to point towards insulin dependent or insulin independent would be things such as usually an insulin dependent. If you have insulin present, then you would have no ketones. Other things when you're thinking about insulin dependent would be, is this exogenous insulin use, or is it due to insulin antibody, or is it an insulinoma? And then when you're thinking about insulin independent things, thinking of things like decreased PO intake, which could be related to malnutrition or alcohol use. Also thinking about adrenal insufficiency or decreased gluconeogenesis due to liver pathology or renal failure, or increased consumption of glucose, which we see in critically ill states such as sepsis or in cancer because of the Warburg effect, where you have increased utilization of glucose by the cancer cells. And then when we're thinking in this case, we knew that the insulin level was high during the hypoglycemic event, so we were thinking this is insulin dependent. So when we're thinking this is insulin dependent hypoglycemia, the negative sulfonylurea screen was important to rule that part out. And the other thing that was important is the C-peptide level to differentiate exogenous versus endogenous insulin. So in this case, the C-peptide was also high, so we were thinking more of endogenous insulin. And then other things we talked about were adrenal insufficiency and looking at different clues in the labs to guide whether that might be playing a role. And when we're thinking about adrenal insufficiency, hyponatremia is commonly seen, but potassium can be normal, especially in primary adrenal insufficiency. And then other things in this case that pointed away from adrenal insufficiency were the weight gain, as well as some of the other features. And then the other thing we talked about was the insulin tolerance test. So when you have hypoglycemia, you can't use the adrenal stimulation test. So the insulin tolerance test is basically when you get hypoglycemia, which you should see an increase in cortisol when you have hypoglycemia. And if you don't see that, that would lead you towards the diagnosis of adrenal insufficiency. So thank you everyone for joining, and this was really special endo VMR.
Bye, everyone.